Hello, everyone. Our topic today is about postoperative pain. Medicine, is it art or science? We'll try to answer this question in this presentation. Objectives, definition of pain, total pain, acute, chronic, and transitional pain, WHO Analgesic Ladder. We'll talk about IV PCAs, epidural PCAs, regional nerve blocks, and we'll conclude our presentation with take-home messages. Definition of pain. According to the International Association Study of Pain, pain is an unpleasant sensory and emotional experience associated with actual or potential tissue damage or described in the terms of such a damage. Total pain was coined by Dame Cicely Saunders, and she suggested that pain can be understood as having physical, psychological, social, emotional, and spiritual components. The combination of these elements is believed to result in a total pain experience that's individualized and specific to each patient's particular situation. Again, pain is physical and non-physical. As far as physical pain, we have three types of physical pain. Could be nociceptive, could be inflammatory, it could be neuropathic. Nociceptive means non-neuronal tissue damage, somatic or visceral. Inflammatory is defined as increased sensitivity due to the inflammatory response associated with tissue damage. Neuropathic pain is arising as a direct consequence of a lesion or disease affecting the somatosensory system, whether it's central or peripheral. And then we have the non-physical that we just talked about, emotional, social, and spiritual. Another definitions that you need to understand here is acute, chronic, and transitional pain. Acute is the pain that resolves with healing of the causative agent and has a protective biological function to protect against further injury. Protective reflexes include withdrawal, muscle spasm, and autonomic reactions, while chronic pain is a pain lasting beyond expected recovery period and identifiable pathology is insufficient to explain the pain state. It disrupts sleep and normal activities of living and doesn't serve a protective and uh, adaptive function like acute pain. Transitional pain is kind of a recent, terminology, and basically, transitional pain care is focused on treating patients who are at risk of transitioning from acute to chronic pain following surgery to prevent the development of chronic pain and related disability. Acute postoperative pain guidelines. According to the American Pain Society published clinical practice guidelines for post-surgical pain management, there is an evidence that evidence-based recommendations that support using a variety of analgesic medications and techniques, as well as non-pharmacologic interventions. Multimodal therapies are recommended. Multimodal analgesia starts from transduction, conduction, transmission, modulation, perception, and CNS responses. So basically, you can intervene with any of these 6 levels of, analgesia, whether you're using, non-pharmacologic or pharmacologic techniques, or even injections and peripheral nerve blocks. South African acute pain guidelines, cognitive behavioral interventions, recommended reassurance and provision of information. Also, attentional techniques such as imagery, distraction, and music therapy. And also, they recommended hypnosis, especially in certain, you know, acute procedural or minor procedures. They also recommended STENS unit, uh, although it's not shown to be very effective in postoperative pain. Acupuncture, um, massage and manual therapy is not in use in postoperative pain. Heat and cold therapy can reduce opioid consumption after orthopedic trauma. WHO Analgesic Ladder modified. As you know, WHO has developed this ladder for chronic cancer pain. This was maybe in the mid 80s, and it has basically three steps: first, second, and third. Now we added a fourth step for nerve blocks and epidurals and PCA pumps and so forth. Again, the other modification made here is, in acute pain, we start from above and go downward. And as far as chronic pain, whether it's cancer or non-cancer, we go from down upwards. So step one is basically non-opioids plus adjuvant. Step two, we add weak opioids such as codeine and tramadol. And step three, we add strong opioids. Quiz of the day. Which of the following factors is likely to influence postoperative opioid requirements? Preoperative pain sensitivity, pre-surgical opioid tolerance or history of drug abuse, psychological factors including catastrophizing and anxiety, age, all of them. The answer is E, all of the above. Patient-controlled analgesia. This is something that was introduced to keep the therapeutic range of the medications within the analgesic corridor. Otherwise, what happens if you give a short-acting medication, whether IV or orally or whatever, you know, it will go beyond the analgesic level, giving the patient euphoria, and then within 1 or 2 hours, it will go down, fluctuating between euphoria and lack of analgesia. And this, of course, will induce a craving to the patient to use this medication more frequently. The whole idea of the PCA is to keep things within a therapeutic range. So these are the PCA advantages. The primary advantage is to shorten the interval from patient divine need to the time of actual analgesic administration. There has been research that showed that by the time the patient asks for a pain medication, it takes around 45 minutes in a hospital setting to administer this medicine. Also, PCA could be more useful in immediate relief of incidental pain. It also gives a greater sense of personal control over their pain. PCA or PCEA. PCEA is the patient-controlled epidural analgesia settings. We have a loading dose, we have a bolus dose, we have a continuous infusion, we have a delay interval, and we have a 1 hour limit. The loading dose is usually 2 times the bolus or demand dose, and it's given to shorten the time it takes to reach steady state. Bolus dose is the most important, of course, is the patient-initiated dose, and higher concentrations are available for palliative patients and double strength for severe acute pain. Continuous infusion is not to be given in opioid naive patients usually, but if the patient is opioid tolerant, we're going to talk about this later on in the presentation. Usually, the continuous infusion is 2 times the bolus. Delay interval is the interval between different bolus of demand doses. And it depends on the Cmax of the drug, or in other words, the time to reach the peak for the drug. So something like fentanyl might need a shorter duration, like maybe 6 minutes, while, for example, morphine needs longer period, like 15 minutes, because it takes longer time to reach the peak. Hydromorphone, because of you know the solubility is somewhere between the fentanyl, which is the highly lipid soluble, and the morphine, which is more water soluble, is somewhere in between. So it would be probably around 10 minutes. I'll be honest with you. I'm not, uh, practically speaking, I just, for I always just choose one number. Usually it's around 10 minutes to, so we lessen the confusion between nursing and physicians. So usually we use certain templates, and we usually utilize 10 minutes in our PCAs. 1 hour limit is the maximum amount of drug to be dispensed in a defined period of time. Of course, this 1 hour limit has no use in palliative setting where we're using pretty high doses. PCA indications. The prime indication for PCA is the patient who requires parenteral analgesia, example, severe pain, or other routes of administration is not really usable. Incidental pain or breakthrough pain. Incidental pain is pain related to certain movement or a certain, uh, you know, uh, action. For example, patient coughing. Patient is, sitting up. He will get this breakthrough pain. It's kind of usually predictable, but it comes pretty fast, and you cannot really control it. With regular medications, you need something that works pretty fast. That's why we're using the PCA. Pain patterns that are not predictable is another indication for PCA. PCA is also indicated for use as a method of a rapid dose titration. Dose finding in acute severe pain. PCA is an effective, safe, and well accepted treatment for postoperative pain, sickle cell crisis pain, and cancer pain. PCA contraindications. First, absolute contraindication. Patient is unable to understand the concept behind the PCA. Allergic reactions to the selected medication. Coagulopathy in cases of patient-controlled epidural analgesia. Relative contraindication include chronic renal failure, sleep apnea, and anticipated analgesic needs less than 24 hours. I want to say that I've had this scenario very few times where the patient is not capable of utilizing the PCA. And I remember a case where the patient actually had some sort of a mental disability, and they were utilizing the PCA for him. Of course, this is not a good idea. Patient did not use any of the PCA bolus doses at all, and he was hurting. So of course, it doesn't make any sense. So we kept it. We did discontinue the PCA, and we kept it as needed. And there was uh, a patient, one of his family members next to him, and he would ask the nurse to for pain medication when the patient is hurting. Also, I mean, if you're having a surgery that will not need more than 24-hour, pain control, it's not a very good idea to start a PCA because of its expense, of course, and you can always deal with this with just as needed type of pain medications. Most commonly used pain medications are opioids, okay, morphine and others, whether it's in the IV PCA or epidural patient-controlled epidural analgesia. Local anesthetics are used in the epidural patient-controlled epidural analgesia, such as bupivacaine, alpha-2 agonists, they, such as clonidine or dexamethasone. NMD antagonists can be also added to the opioids, such as ketamine. NSAIDs are also utilized sometimes, such as ketorolac. Antiemetics can be also added to the PCA machine. Generally speaking, guys, I want to say that the most important drug in the uh, PCAs or PCEA is opioids and local anesthetics as far as epidurals. Okay, so these are some of the machines. There are ones that are disposable available in hospitals right now, and these are comes with different volumes, and usually can basically give analgesia up to 3 days to the patient. While the upper one here is something that we uh, carry in the hospitals and comes with a preset, infusion bag and tubing, and you can utilize it, basically until the patient, switches from PCA to something else. Uh, opioids. Uh, opioids are basically five categories. Okay, and I like to really throw this slide described by Dr. Fuden, and I was one of the few people really, learned directly from this pharmacist. Um, he always stresses on understanding the chemistry of opioids because it will make you understand a lot of the side effects and also indications of these medications. So we have five groups. We have phenanthrines, benzomorphins, phenylpipridines, diphenylheptanes, and then phenylpropylamines. The phenanthrines are the morphine-like drugs. Benzomorphins are basically the drugs like diphenoxylate and loperamide, and these basically drugs that we use for constipation. And then meperidine-like drugs such as fentanyl and others, remifentanil, alfenta, sofenta. Diphenylheptanes, methadone, and propoxyphene. Propoxyphene is not used anymore. It was a weak opioid. It was in the class 2 category and the WHO, like codeine. But for so many reasons, they decided to stop it uh, because there are other alternatives, and also the side effect profile of propoxyphene. Methadone is used for, addiction and also for chronic uh, intractable pain, whether it's cancer or non-cancer. And then we have the famous drug tramadol, and the cousin of tramadol is the pentadol, and these are dual drugs that work through dual mechanism of action through uh, you know uh, inhibiting the reuptake of catecholamines in the brainstem, and also they are mu agonists. Mechanism of action of opioids are basically one of the undertaught areas in pain medicine. Opioids work by attaching to a 7 transmembrane G receptor complex, which activates a G protein and inhibit the adenylate cyclase, and this will lead to a reduction in cyclic AMP. And this basically will reduce the intracellular calcium, and this will reduce the neurotransmitter release. Besides, it will increase the potassium efflux, and this will hyperpolarize the membrane. This is just, a diagrammatic, depiction for opioid receptors. You got the 7 transmembrane G protein coupled receptor, and you can see it will reduce the cyclic AMP, and thus it will reduce the intracellular calcium and reduce the release of neurotransmitter, while it will increase the potassium efflux and hyperpolarize the membrane. Opioids receptors are 5 types. The most important ones that you need to know is the mu, delta, kappa, nociceptin, and zeta. Um, I'm more concerned with the mu, of course, and the kappa. Okay, so we have different drugs based on their selectivity to different receptors here. So we have a partial agonist such as buprenorphine. We have pure agonists, like most of the opioids are pure agonists, and then you have agonist antagonists such as nalbuphine, a famous drug used in Egypt nowadays. It's an agonist antagonist. It's an agonist on kappa and antagonist on the mu receptor. So it has a different profile than the rest of the opioids. It gives you analgesia, but the side effects are much less, which basically related to the mu activity because it's a mu antagonist. And then we have the pure antagonists like naloxone and naltrexone. And also we have what we call the PAMORAs, peripherally acting mu opioid receptor antagonists, such as methylnaltrexone or Relistor that we use for opioid-induced constipation. Okay, that's basically the intrinsic activity of these drugs. As you see, partial agonist plateaus pretty early than the full agonist, and this makes these drugs less uh, liable to cause respiratory depression. Drug metabolism is very important in as far as opioids. A drug is metabolized in the liver either by the P450, which is called the phase one, or a phase two, which is called the conjugation. And then the metabolites usually excreted either in the urine or the bile. These are the P450 enzymes, the most famous of which is 3A4, which constitutes around 36%, and CYP2D6 is next to it, which constitute around 19%. So from this table, you can understand the different drug interactions. And I'm going to just give you a couple of them so give you an idea the importance of these drug interactions. For example, fentanyl is metabolized by the 3A4 system. Okay, it's this enzyme is inhibited by the macrolides, like let's say erythromycin, okay, or the azoles like fluconazole, for example. Now, when the fentanyl is metabolized, it goes to inactive metabolites. So let us say I give a patient erythromycin on top of fentanyl. He will have more of the parent drug, which will actually can intoxicate the patient if given together. All right. While if you give an inducer like phenobarb, for example, with the fentanyl, it will activate the enzyme, so you will have more of the inactive metabolites, so the fentanyl effect will be less. So this is how it works. So you got to know these drug interactions. In fact, actually, a very simple thing like grapefruit juice can make a difference with your opioids. Okay, the drugs metabolized by the 2D6 are inhibited by the SSRIs or the selective norepinephrine reuptake inhibitors. And this gives actually active metabolites when they're metabolized. So the effect is opposite to the first class, the 3A4. So let us say oxycodone. Let us say I give SSRIs with it. It would give you more of an active metabolite like oxymorphone, which is more stronger than oxycodone. So it will strengthen the effect of the oxycodone. While if you give an inducer like rifampicin, for example, this will inhibit the enzyme, the 2D6, and make these drugs less potent. So again, this gets us to the question of the that we gave at the beginning of the presentation. Is this science or art? Conjugation. Uh, these have less drug to drug interactions, okay, like morphine, for example. Unfortunately, the metabolites of the morphine can accumulate in renal failure patients and can cause, you know, neural toxicity and delirium. Like this picture here, morphine, 50% goes to form M3G, 10% M6G. The M3G is excitatory, the M6G is analgesic. And when you really, um, have renal impairment, let us say related to dehydration, or let us say chemotherapy, or whatever the cause is, you can accumulate this metabolite and you can cause mixed delirium here to the patients. IV opioids for used for PCAs. These are the ones that we use in practice. I want to say that meperidine should not be used for more than 48 hours because of the metabolite of meperidine can cause seizures, especially with abnormal renal function. The commonest IV opioid we use in PCAs is morphine and fentanyl. Usually, we reserve fentanyl for patients with renal failure or patients allergic to morphine. Spectrum of opioid-induced neurotoxicity. I like to explain the neurotoxicity related to opioids as a spectrum, starting from opioid tolerance, going up to seizures. Um, and then you have, see here, you can get delirium, you can get a condition called opioid-induced hyperalgesia, where the opioids actually turn like you know, a stimulant agent for pain instead of reducing the pain, it will increase the pain. Also, myoclonus is a very important sign for opioid-induced neurotoxicity. Art of medicine. Uh, I like this, picture here. Uh, Top side effects of opioids. We have 10 side effects of opioids: perioditis, allergy, pseudo-allergy, urine retention, constipation, nausea and vomiting, contraction of sphincter of Oddi, somnolence, meiosis, tolerance, opioid-induced neurotoxicity, cognitive changes, hypogonadotropic hypogonadism, ADH release, and respiratory depression. Meiosis is not a sign of toxicity, it's a sign that the patient has received opioids. The only opioid that doesn't cause meiosis is meperidine because it has an atropine-like action. It can cause pupillary dilatation. Anaphylactic reactions is a very important uh, side effect with opioids. And you have to differentiate between anaphylactic and anaphylactoid reactions. Anaphylactic reaction is treated with epinephrine. The only drug for anaphylactic reaction is epinephrine. And with anaphylaxis, you have usually angioedema of the face. Okay? You don't see this with anaphylactoid reaction. Sometimes they call it allergy and pseudo allergy. Same terminology, by the way. Okay, so this is a difference between anaphylactic and anaphylactoid. Anaphylactoid is not related to IgE. It's just a excessive idiosyncratic histamine release from mast cells. Has nothing to do with a hypersensitivity reaction, and thus it can happen from the first exposure. While anaphylactic reaction has to be second exposure. Okay, you have to sensitize the body, and the second time you release the IgE that will release the histamine from the mast cells. The treatment is different. With anaphylaxis, you need epinephrine. With anaphylactoid, you need antihistaminics. Opioid-induced nausea, usually it's short-term, and it's related to basically triggering the chemoreceptor trigger zone, which is outside the blood-brain barrier. They will actually cause irritation to the vomiting center that's inside the medulla, and it will actually start the whole process of the nausea and vomiting. Opioid-induced constipation. This is a very important issue, especially patients receiving oral medications, oral opioids. And basically, opioids can constipate the patient. It can affect any part of the bowel, starting from from the esophagus to the rectum. So that's why usually I check the patients after surgery. When they say that they're hurting, I want to always make sure that this is not related to constipation. It could be also something like urinary retention. I need to know whether this is surgical related or basically related to the medications, because it makes a huge difference. If it's surgical related, probably I will increase the pain medication given to the patient or increase the frequency. But if it's really related to constipation or urinary retention, for example, then you need to do the opposite completely. And you need to give anti-constipation agents. Urine retention is also another side effect that can happen from IV or oral opioids. And again, you need to know whether it's, patient is having urinary retention or having pain from the surgical side, because the treatment is totally different. Again, here you put a Foley, this one you need to increase the opioids. The opioids causes constipation. Constipation actually can cause urinary retention, and opioids in general can cause urinary retention, especially if it's epidural or intrathecal opioid. Itching is another complication or side effect from opioids, and except for morphine, the treatment is basically one of these agonist antagonists, like naloxone, for example, nalbuphine. Otherwise, if it's related to morphine, because morphine actually induces histamine release from the periphery. Another important topic here is the opioid tolerance versus opioid naive. I'm not going to go through all of these three definitions, but I want you to just uh, take the last one as the symptom. You can ask the patient whether he received opioids in the last 30 days or not. And if he does, then he's an opioid tolerant patient. And if not, then he's an opioid naive patient. Opioid withdrawal timeline, it's very important to understand that if the patient comes to you and he's on opioids already from home, you need to give him some opioids so he doesn't get into withdrawal symptoms. It usually peaks at the 72 hours after, stopping the opioids. Respiratory depression. You know, unfortunately, opioids can increase the likelihood of respiratory depression by actually, shifting the curve of the, you know, alveolar ventilation to the right and below. And this will allow you to basically have, more chance to have respiratory depression, especially if you add barbiturates to it or benzodiazepines and use it in the patients that have already COPD or lung disease. The only treatment of respiratory depression with opioids is basically naloxone. Okay, be careful. First of all, the main indication is respiratory rate less than 8. And when you use Narcan or naloxone, please dilute it in 10 cc and give it very slowly because you can cause acute pulmonary edema if you do it pretty fast. Because you will get a surge of catecholamines that will uh, come all of a sudden by blocking the opioid receptors. This can cause acute pulmonary edema. I've seen a couple of cases. Now, after you give naloxone, probably the patient might actually re-narcotize again after a couple of hours. So you need to give an IV drip of naloxone uh, afterwards, so to prevent the recurrence of respiratory depression. All right, this gets us back to, are we doing art or are we doing science here? We'll talk a little bit about some of these nerve blocks. The most important one is the epidural analgesia, especially in thoracoabdominal surgery, because it reduces the incidence of atelectasis, ileus, and thromboembolic complications. That's the main role of doing a thoracic epidural, in postoperative period. It requires more careful monitoring as local anesthetics can cause hypotension and opioids can cause respiratory depression. So you have two major complications can happen from doing a thoracic epidural. And you can do a PCA, what we call PCEA, exactly the same concept like, you know, and the IV PCA. This is how you put the epidural catheter. Of course, needs, a specialist to place this catheter in. Most of the time, we put a local anesthetic and opioids by the epidural catheter. And I want to say that, adding a local anesthetic is basically meant to block the somatic pain, while the opioids block the visceral pain. And that's why we add them together so we don't get the side effects of neither the local nor the opioids. The local anesthetics can cause hypotension, numbness, and weakness, while the opioids can cause respiratory itching and urinary retention. These are the complications of epidural analgesia, traumatic injury, chemical injury if accidentally injected with the wrong contaminant here. Infectious meningitis, epidural abscess. This is pretty rare, but it can happen, of course. Mass lesions like epidural hematoma. This is more common with epidurals, especially patients that are anticoagulated. Local anesthetic effects such as hypotension and weakness, and opioid side effects such as urinary retention, respiratory depression, and itching. Arachnoiditis, again, this is a complication from wrong contaminant injected in the epidural space. Epidural hematoma. And that's why we have certain regulations as far as using the anticoagulants and epidural analgesia. For example, patients that are taking enoxaparin, we have to discontinue the catheter after 12 hours from the last dose. Um, if the patient is taking therapeutic dose, we have to discontinue the catheter after 24 hours from the last dose. Resume enoxaparin 2 hours after removal of the catheter. So these are just kind of, some of the regulations. Uh, Very important to follow these instructions by the anesthesiologist because you don't want to get an epidural hematoma inside your epidural space here. Heparin also has its own, restrictions here. For example, if you're using a prophylactic dose, you have to DC the catheter after 4 hours from the last dose. And usually you need to resume the heparin 1 hour after removal of the catheter. These are just guidelines from the American Society of Regional Anesthesia, and they're very important to follow here. Also, epidural abscess. You know, this could be catastrophic, of course, and it can happen. It's pretty rare, but can happen, especially if you have an immune compromised patient. So again, with epidural, you need more, follow up than a PCA. You need to check cognition. You need to check vitals, blood pressure, heart rate, respiratory rate, pain score. You need to check sensory and level and motor block. And you have to document, these in your chart or in your system here, because this has a lot of medical legal, importance here. We use a scale called Bromage scale for epidurals to to detect whether the patient has a motor block or not. Patient Bromage 0, he does not have any, a motor block. Bromage 3 is patient completely blocked. And in this situation, you have to call the anesthesiologist because the differential is either patient had, you know, the intensive block, or a patient has an injury in his spinal cord. So usually, most of the time, the anesthesiologist will examine the patient as a whole, and will try to follow up with the patient, make sure that uh, patient gets an MRI if he's suspecting like a epidural hematoma, for example, or not. Okay. Nowadays, there is more interest in doing peripheral nerve blocks than doing central blocks like epidurals. And the reason is they're easier to perform, they have less grave complications, they can be performed in anticoagulated patients, and even they can be performed in patients with spine injuries. The only drawback of these blocks is they are less quality than the central block as far as pain relief. But when you look at the overall, advantages, it's a better package than the central blocks. And you can also add some IV opioids to it, and you will have a good, post-operative analgesia. At the end here, I want to thank everyone here, and this is basically going back to school. Uh, these are the schools that I went through in my life here. First one on the left is Al Nasr School in Heliopolis, and then Ain Shams University, where I got my medical degree, and then UMS, where I, got my board certifications. Take home messages. Pain is an unpleasant sensory and emotional experience. associated with actual or potential tissue damage. Uh, Patient-controlled analgesia is the technique whereby patients can self-administer parenteral analgesics. The primary advantage of PCA is to shorten the interval from patient-defined need to the time of actual analgesic administration. Patient-controlled epidural analgesia offers a higher quality of analgesia than IV PCA, especially in thoracoabdominal surgery, as it reduces the incidence of atelectasis, ileus, and thromboembolic complications. Peripheral nerve blocks offer less quality analgesia than central ones, but with less chance of grave side effects. Thank you so much.